A very big hello to all my dear students. So let's welcome to this T2O series, favorite channel you and I have talked. So आज हम लोग क्या डिस्कस करेंगे? Let's see which clinical vignette we are going to discuss today. We'll read the question together. A 55 years male presents with the complaints of blurring vision, discomfort, and colored halos in his left eye. Okay. So he gives history of similar episode 5 years back. On examination of the left eye, his IOP is 53. That's the reason of the colored halos. Must be causing some corneal edema, right? In the right eye, it is not. So do we not start thinking in the terms of high IOP? Yes. But slit lamp examination of the left eye shows mild corneal edema, because of which there was colored halos with single KP and few aqueous cells. Now, can you guess where we are heading? Single KP, few aqueous cells, high pressures, and middle age, and he's a male. So it's more common in males. What is this condition? The iris is hypochromic with the peripheral iridotomy is already done. Is he a case of acute angle closure glaucoma? No. How are you going to explain the KPs? How are you going to explain the aqueous cells? That happens only in uveitis. The pupils are dilated and reacting sluggishly because of the high IOPs. So anterior segment shows mild nuclear sclerotic changes in the lens. On gonioscopy, both eyes, the angles are open. It is not angle closure glaucoma. Angles are open. Fundoscopy CD ratio is normal in both eyes. We all know the normal is less than equal to 0.3, but we generally suspect only when it is more than 0.6. Right? So most probable diagnosis. I think majority of you can guess it is glaucomatocyclitic crisis, which means that uveitis which has led to such high pressures. What is the other name? The other name is Posner-Schlossman syndrome. Okay, then how do you explain this iridotomy? It was misdiagnosed as angle closure and iridotomy was done. And in spite of the iridotomy, this patient has the episodes again and again of high pressures and with inflammation and KPs and cells. So when you are looking at the KPs, you see only one single KP in, sorry, this aqueous cells, I'm sorry, we are seeing one single aqueous cell. So it's a very, very less sign of uveitis, but very high pressures. This is glaucomatocyclitic crisis or Posner-Schlossman. So why does it happen? It can be HLA associated. Keep in mind, it may be even associated with H. pylori infection. And it has been seen to be more common in males. These three things you have to remember. So the cause it says is because any inflammation, this inflammation is actually leading to trabeculitis. It is causing very high. Okay? And how? Because if you look at acute congestive glaucoma, just to compare, severe redness, corneal edema, vertically oval fixed dilated pupil. None of this is seen here in Posner-Schlossman. Okay? So please revise this important topic. What question they have asked you is, what is the treatment? Of course, if it is uveitis, I have to give steroids, but steroids will cause increase of pressure, more increase, and damage the nerve. It's already alarming. So what is very important to understand, we do give steroids, but it is only under anti-glaucoma. Okay, so you start anti-glaucoma drugs, control the pressures, start steroids, stop the steroids and continue with anti-glaucoma drugs. That is called a cover. Right? So that was all for today. Hope you enjoyed the session. Thank you so much. Stay blessed and keep smiling.